On October 10, 2012, the Health Council of Canada held its annual symposium, Advancing Integrated Healthcare in Canada, Practices that Work. The plenary session featured Dr. Dennis Kodner, International Visiting Fellow and Co-Director, Aetna Foundation Care Coordination Study, the King's Fund.
Good morning. Bonjour. I'm delighted to be here, and I'm struck by the number of people in this audience, 500 people, I'm told, and that's an enormously large group of people to gather to listen and to talk about, to discuss, to learn about integrated care. On one hand. On the other hand, I'm not so surprised because I went to a meeting in Singapore. It's a small country, and there were 2,000 people in an audience. I guess every health professional in Singapore, whether it was the people in the minister's office or the people working for hospitals, clinicians, academics, researchers, policymakers, all gathered around this meeting to talk about integrated care. And it's clear that integrated care is or health care, from an integrated point of view, is a global buzzword. Whether you call it the integrated care or soins intégrés or atención integrada or integrale zorg in Dutch or integrierte Verzorgung in German. Well, whatever you call it, it's clear that this is a word which has taken on important meaning in our deliberations about reforming health systems at the policy level and in the trenches where the most important work gets done, providing service and supports to people who have very, very complex needs. I'm going to talk about integrated healthcare, the what, the why, the how, and the how not. This is kind of based on 25 years of my work with integrated care. I have been involved in designing integrated care programs, in developing and implementing them, managing them, evaluating them, and studying them. And it's also based not only upon my experience in the United States, which I spent a large amount of my career, but also in other countries. So I've done work, as you heard, in Canada, and I've taught for 20-something years in the Netherlands, and I'm now, as you hear, I don't speak the Queen's English. I'm an international visiting fellow at the King's Fund, where I'm focusing on integrated care, looking at coordinated care, another way of looking at integrated care in the British context, and trying to understand what the implications are for the U.S. health system. I'm working with the clinical commissioning groups and primary care trust around the issue of how do you develop integrated care strategies for chronic complex populations from a primary care point of view. I'm doing work in Singapore looking at an integrated care strategy for kind of a hospital-based hub and spoke approach to integrated care for the entire country of Singapore. I'm doing work in the Países Vascos, the Basque Country, on integrated care strategy for chronic illness. And indeed, one thing I've learned is that whether we talk about the frail elderly, which I'll focus in on today, or we talk about people with physical disabilities, or people with intellectual or developmental disabilities, people who have chronic persistent mental illness, people with substance abuse problems, all these are very complex populations. People with multiple comorbidities, with complex chronic illness, all these populations have a complex set of needs which demand integrated care. And I've also found that what works for one population works for the other, that on the one hand, there's no one-size-fits-all integrated care. On the other hand, the components of successful integrated care models work for all these populations. Now, I talk very fast. My wife tells me that, well, I'm a fast-talking New Yorker, but she tells me that I actually speak slower than I did when she first met me about 30 years ago, although I notice when people sign for me at meetings, there's smoke that usually arises from the hands. I hope you can follow there's no bouncing dots, but I hope you can follow me. I'm going to first talk about integration, integrated care. I think it's a curious concept. Well, you know what a Rorschach test is. For those of you who are psychologists, take mental health courses, psychology courses, psychiatry courses, and, you know, the doctor holds up the chart and he says, what do you think this is, you know? And this is the inkblot, and he says, what do you think it is? And everybody says, I think that's a mother with a child. Somebody says, no, it's a beautiful flower. And in fact, in some ways, when we talk about integrated care, it's a kind of a Rorschach test, that we really don't have a shared understanding about what integrated care means. That's part of our problem. Language is important. It's hard to build a system around integration. It's hard to create integrated solutions to very complex populations unless we have a common understanding of what the concepts, what's what's the terminology, what the topologies are. And I think that's a big problem around the world, that you have 100 people and there are 125 different definitions of integrated care. So I'm going to talk a little bit about integrated care and integration, kind of deconstruct what integration, integrated care means, at least my perspective on integration. I'm going to talk about some models of integrated care that seem to work. Some of them you, I'm sure, all are familiar with, and I know some of my colleagues from Quebec in the audience can speak about them better than I can, from Prisma or CIPA, and certainly there are other projects and innovations throughout Canada. The work that was done in Choice in Alberta, and some of the chronic care management strategies in Alberta are very, very impressive. The work I've done work in when I did some work in Capital Health, I became familiar with those. When you look at British Columbia and you look at the work that the Vancouver Coastal Health Authority is doing with their teams, I am extraordinarily impressed, and I know Fraser also is doing some very interesting work. So there's a lot of stuff going on throughout Canada, but it's very, very clear that there are more, the world is littered with integrated care programs that don't work and have been very, very unsuccessful. I think it's important to understand what the ingredients of success are. So first I'll talk about what integration and integrated care means. Then I'll talk about some of the successful models. Then I'll talk about some of the lessons. What are the key ingredients of successful integrated care programs? And then some kind of personal perspectives on where to go and where not to go, how to avoid some of the dangers of integration, because in fact it's a very, very difficult journey to create integrated systems of care. I think if you begin to talk about integration, integrated care, it's important to talk about complexity. I think that's an enormously important issue because we all live in a world where complex patient populations are the challenge of healthcare systems. Populations with so-called complex illnesses are growing significantly as a result of rapid population aging, increasing numbers of people, particularly over age 85 and older, and also people with onset of lifestyle-related chronic illnesses. So that's the first reason why we need to think about the notion of complexity. Health systems are largely single disease-oriented systems. They're very, very acute-oriented health systems, and they are very much oriented to short-term treatment of disease. And we're talking about people who need complex ongoing support and services for not only their medical needs, but for the health and for the social needs as well. And finally, complex conditions require a very, very broad package of services. These are relatively expensive, they're difficult to manage, and they demand whole new ways of organizing and delivering care. So complexity is an important challenge to address, and that gives rise to the need to talk about integration. Now, certainly the frail elderly are a very good example of what we talk about when we speak about and we think about complex populations. Frail older people are about 15 to 20% of all people over the age of 65. They have a mix of health and social or long-term care needs over time, and there's a very, very complex set of needs that they have. They are functionally independent in ADLs and IADLs. They are health impaired, sometimes cognitively and mentally. They have multiple ongoing comorbidities and needs. They have high risk of hospitalization and institutionalization. There are frequent interactions between the providers and transitions within and between the systems and settings. There are access, coordination, and continuity problems, and there are carer burden and stress. And I guess that's why most efforts around the world to address the issue of integration, integrated care start with the frail elderly population. If we can do a good job in addressing the complex needs of this population, we could do a good job in addressing complex needs of other populations that we have to deal with in our health systems. So what are the weaknesses that we have to confront in not only caring for frail older people, but for other people with complex chronic illness? Well, there's our health systems have a greater emphasis on cure versus care. We've built these acute-oriented health systems where the hospital is at the center of the system. It absorbs the greatest amount of money. It's the way we train physicians, nurses, and other health professionals. It's the technology that we use, and the inevitable result of this is a system which is ill-equipped to deal with the challenges of complex chronic illness. So there's a great emphasis on cure versus care. There are fragmented, misaligned policies policymaking, planning, regulation, and financing. A lot of the emphasis in creating integrated care solutions is at the meso and micro levels, at the level of the patient or the client. But in fact, it's, as I'll show you shortly, that integrated care is a complex simultaneous equation. You really can solve the problems of fragmentation and just disjointed care without dealing with what goes on at the top, the regulation, the policy-making system, the financing system. And so we have a fragmented, misaligned policy-making, planning, regulation, and financing. We have an inadequate long-term care protection, particularly for nursing home care. And maybe you'll be surprised to know or to learn that even in England, where we think that the NHS covers everything, long-term care is the responsibility of the local authorities, municipalities, and the county governments, and that there isn't a national mandate to cover nursing home and other kinds of non-medical home supports, that the funding levels are different from area to area in England, and that in fact, even though there's a standard assessment technology that's used, in fact it's used differently from place to place. So a person who might get services in one part of London might not get services in another part of London. So there is an enormous problem of getting access to long-term care. In the United States, we don't have a national long-term care program, and that in fact long-term care is either paid for out of pocket largely, or it can be paid for through private long-term care insurance, which is a small but growing market. And in fact, most people who need long-term care end up getting long-term care coverage in a nursing home or in the home and a community setting through Medicaid. And Medicaid is the federal state program that's oriented to people who are medically and financially indigent. This is kind of the 47% of the people that one of our candidates in the United States referred to recently. And these are not poor people, by the way. These are people who had to spend down their life savings in order to get long-term care support at home or in a nursing home. So long-term care protection is an enormous challenge in many parts of the world, even in Canada. To be sure, you have this great Medicare system that is different from province to province, but in fact, we know that some provinces fund more long-term care services than others. There's an imbalance between institutional and community-based services. I think that's a major challenge. There's poor collaboration at the organizational and provider levels within and between health, long-term care, mental health, and other sectors. And I think that the most important observation I can make about what's wrong with our system is that there's a lack of a single provider team or an entity that's responsible for all care and outcomes provided to the client or patient. Who owns, besides the patient and their family, owns the client? Who owns the patient? Who's responsible for their care? And I think that's one of the glaring deficiencies in all healthcare systems around the world, that there's no one entity, no one group of people that's responsible for that care and those outcomes. Now, I guess, I'm in Canada, to be sure, and I know that Wayne Gretzky is a very important person in Canada. You would probably not know that he's a specialist in integration. He's an integrationologist, I guess, as well as a hockey specialist. And he said, you know this very famous slogan, we have to skate toward where the puck is going to be, not to where it's been. And indeed, that means we need to skate to integration. Integration is kind of the solution to a lot of the problems I've just enumerated to you. But we need to first think about why there's such a poor fit. Why are the problems that I've just described, why are they really occurring? And I think that there are kind of three main reasons why we confront a complex system that's unable to deal with complex patients. The first is there are many jurisdictions, system boundaries, institutions, and professionals. They don't work in tandem or together. There is conflicting policies and regulations and financing, and the British would call them commissioning schemes and budgets, different ways of paying for different parts of the care that people need and receive. And finally, I guess an anthropologist would say there's a lot of tribalism going on in healthcare. There are conflicting, differing professional identities and roles in different cultures and different languages, different clinical philosophies, different service delivery methods, and different power relationships. And I think these are we underestimate this as challenge, but this is probably one of the biggest challenges in trying to organize and implement and create a successful integrated care solution in our systems around the world. Even if we have a well-defined integrated care solution to our systems, a lot of this can be undone by the fact that we have these kind of cultural problems in our system that's been with us ever since modern healthcare has been with us. And so the solution, as Gretzky would say, and as Kodner would say, is that it's integration, integrated care. There are a lot of definitions. I collect definitions in English and in Dutch and in Spanish and in French and Italian and Portuguese. Well, there are hundreds of definitions. There are WHO definitions. There are all kinds of definitions. I like this definition. It's my definition. It's Cor Spreeuwenberg is the former dean of the School of Medicine and Public Health at in Maastricht University. He's a physician, a GP Hausarztin, a house doctor, and a health services researcher, and myself did this a number of years ago. And we said that integration is a coherent set of methods and models on the funding, administrative, organizational, service delivery, and clinical levels designed to create connectivity, alignment, and collaboration within and between the cure and care sectors. It's not just about healthcare. It's about healthcare, social services, mental health care, and other kinds of services that complex populations ultimately end up needing. And what is the purpose? It's to enhance quality of care and quality of life, consumer satisfaction, patient or client satisfaction, and system efficiency for patients who have complex problems which cut across multiple providers, multiple services, and multiple settings. And if you, in fact, can figure out a way of integrating the system, the result is something called integrated care. That's the outcome of integrated care. Integrated care is really the opposite side of the coin, and integrated care is the result. It's kind of a multi-pronged outcomes from integration. Now, part of the problem with integration is that there are all of the other names that we use for integration, which makes it even more confusing. Case management, care coordination, case coordination, transitional care, patient-centered care, what else do I remember? Oh, transitional care, chronic care management. All of these are forms of integrated care. They are forms of integrated care. They all have a common approach, and that's what makes them part of the integrated care family. But I think that makes it very, very difficult to understand. Integration is, as I said before, a complex simultaneous equation. It operates at 3 different levels. Someone said earlier in the introduction, it's a multiple level strategy. And there's the macro level where policy, financing, regulation sets the stage. Integration takes place at the meso level, where provider organizations interact, and it also takes place first and foremost at the micro level, where professionals and patients meet in the caring enterprise. So I think that's it's very, very important to understand. It also has 2 unusual chemical-like properties. Integration is kind of the glue of the health system. It keeps the health system and all the parts of the health system together, and it's also kind of a grease. It makes the wheels, the parts of the health system work better and smoothly work together. And I think that's really unusual to have something which has glue and grease as a kind of a chemical-like component. Well, and then there are different types of integration. There's functional integration. This is integration where the back office support functions are brought together across all units. There is organizational integration, where relationships between provider organizations are addressed, and I'll get to this later, that in fact the big problem in creating successful integrated care strategies and solutions and models and programs is that people begin organizing, kind of integrating organizations first. And that's kind of like reorganizing the chairs on the deck of the Titanic. It's the worst possible thing to do. Organizational integration should be the last thing you should do. You should be focusing on integrating at the level of the client, the patient, the family, and in the community. Professional integration, relationships between professionals. Clinical and service integration, the coordination of care across time, place, and discipline. Normative integration, we really underestimate this. Shared mission, values, and culture. And systemic integration, the alignment of policies and incentives, particularly financial policies. Form follows financing. If you can't align financial incentives, it's very difficult to achieve the full promise of integration and integrated care. And finally, there are kinds of other ways in which organizations themselves can integrate. There's horizontal integration, which you're all familiar with. It's when, for example, 2 hospitals merge or 2 units, 2 medical units merge. And what I think more of as integration is vertical integration, where a hospital, a nursing home, a home care organization, and other kinds of provider or primary care center or GPs or family practitioners all merge into a network or a system or an integrated program. And that's vertical integration. And sometimes that vertical integration also includes the financing of care. So in the US, I guess the best example of a vertically integrated model would be Kaiser and other forms of health maintenance organizations, where the organization, the delivery, and the financing of care is under one roof or one virtual roof. It has to be one organization, it can be a virtual organization as well. In fact, most integration around the world out of the United States is virtual integration, not under one real roof. And what are the main goals of integrated care? Well, there are four main goals. To improve the patient journey experience and satisfaction. If we can't do that, there's no point in doing integration, integrated care. It's to enhance service coordination and continuity of care. It's to strengthen system links between primary, secondary health and social and behavioral and health and physical care. And finally, it's to foster overall improvements in service quality, personal health status, efficiency, and cost effectiveness. So this is exactly what we're trying to do. And my friend and colleague Walter Lutz at Brandeis University talks about three different kinds of models of integrated care. He wrote a very famous paper that appeared a good number of years ago, 2002, in the Milbank Quarterly around the laws of integration. And it's more like the haiku of integration, but it's his notion of what the laws of integration are. And as part of his model, as part of his approach to integrated care, he talked about three different models. He said there is the linkage model, which is the least change approach to integration. It's what most good professionals try to do in a fragmented, disjointed system, work around the system, and try to make it as seamless as possible, given the kind of the complexities involved. You have coordination, which is a much more structured approach to bringing organizations and professionals together around to build services and care around the needs of complex patient populations. I'll give examples of the coordinated model. And then there's full integration, which is kind of what I call the HMO approach, which is the organization, delivery, and finance and care is basically under one roof, which is kind of the American approach to integration, although you find this growing focus on this kind of model around the world. My sense is that as you get experience in a coordinated approach to integration, a lot of countries begin to think about how financing can be integrated into the package and how you can make it a more complete model. But you see that, in fact, these approaches to integration from an organizational point of view do better with certain populations than others. So if it's not about fitting people into the model, it's about creating a model which fits with the needs of patient populations. So if you look at the full integration model, where the financing, organization, delivery of care is under one roof or under one virtual roof, we're talking about, it's a model which works with people who are very severely impaired, moderate to severe impairments, where they're relatively unstable, where they have long-term to terminal needs, where they have frequent acute exacerbations, frequently urgent and acute exacerbations, where their scope of need is extraordinarily broad. It's not only medical care, but other forms of health care and social care, mental health care. And the patients, the clients themselves are weakly self-directed. It's very, very difficult for them to participate in the decisions being made for them in their care. Whereas coordinated care, you could see, while there's an overlap around the severity of the client needs, the stability, the people tend to be more stable than unstable. They have short-term to long-term needs. The urgency is usually mostly routine to sometimes urgent. The scope of need is moderate to broad. It's not as broad as the complex or the fully integrated model. And people are moderately self-directed. They participate in making these important decisions. And using this typology, Lutz's typology, I kind of will describe a couple of different models. First, we have in the United States the full integration model, PACE, Program of All-Inclusive Care of the Elderly. It began in San Francisco at a place called Anlok. It's a Chinese dialect that means peaceful, happy abode. This was kind of an audacious model. It was a senior center. that said that there's really something wrong with the way in which we provide health and long-term care to older people, and that wouldn't it be good if we could, in effect, get paid for all of the health and social services people needed and address their needs, in effect become an HMO. It's an organization at the lowest end of the feeding chain. It's not the hospital, it's a social service agency. And so this is a model based on an adult day health center being the center of a managed care approach to a very complex population. And what do we know about the model? It decreased hospital, inpatient, and nursing home use. It increased utilization of outpatient medical care therapies, home and community-based services. It had a positive impact on Medicare, American Medicare system, in terms of the acute care costs vis-a-vis people who were not enrolled. You had to leave the traditional system and enroll in this program. Favorable health status outcomes, overall satisfaction with care arrangements, positive but inconsistent impact on physical functioning, and differences in quality of life. In England, there's a Torbay model. Torbay is kind of the closer you get in England to the Sun Belt. It's a part of England where people retire. About 24% of the population, 23% are over 65. That's a very densely, a large elderly population, very densely populated. And the Torbay Care Trust in 2005 integrated all health and social care. The director of the Care Trust was responsible for acute services and hospital services and primary care and other services, was also named the director of social care for the municipality. So he, in effect, controlled all of the health and social care across the health and social care divide. And this is a model which is based on 5 health and social care teams organized around GP practices. There was a single point of access into the system. And as you can see, well, you'll see in your slides, but I don't have very much time, but there was improved access to services for users and GPs, enhanced coordination of health and social care, reduced hospital admissions, length of stay, and emergency department use, eliminated delayed transfers of care, improved staff morale and job satisfaction, and they actually generated savings enough to pay for more service, a gap-filling service in the system. Well, Prisma, as you perhaps are most familiar with, I'm not going to really spend much time. I know there are people, Michel Reich and others from Quebec, that are giving presentations on Prisma. Prisma is more an example of the co-ordination model. It is in the province of Quebec. It was pilot tested in 1997, 1999. This is earlier results. I know there's more, there's later results, which I'm sure the group from Quebec will talk about at this meeting. But again, it's an example of a less structured model where not all the services are included and coordination is the strategy. The Rovereto model. We never think of Italy as being a part of the Silicon Valley of integrated care. Maybe it's the wine, maybe it's the spaghetti, we're not exactly sure. But in northern Italy in 1995, there was a model of integrated health and social care that was introduced. It was based in the hospital-based geriatric unit. It integrated with the local health authority, kind of an NHS-like authority for health services, and also the local municipality, which is responsible for social service, like in England, the same health-social divide. They reduced admissions to hospitals and nursing homes in the intervention group, and it occurred later and less common than in controls. Health services were used to the same extent, but controls received more frequent in-home visits by the GP. There was improved physical functioning, reduced decline in cognitive status. And the financial savings were roughly, in US dollars, about $1,800 a year in 1998. Not a lot, but if you multiply that times the number of people eligible, it's pretty favorable. So is integrated care the answer to all the problems? Why should we do this stuff? It's enormously challenging unless we know the evidence supports it. And the evidence suggests that it expands access to including primary care. It enhances coordination and continuity. It improves health and functional status. It reduces hospitalization, nursing home admissions, and length of stays. It improves user experience, quality of life, and satisfaction. It, to a lesser extent, reduces care burden. And of course, where the jury is still out is about efficiency and reducing costs. We don't really have good understanding of how integration saves money. And we also don't know what elements of integration produce the best outcomes, the most outcomes. And finally, perceived improvements in partnership working and greater focus on governments and guidelines. So what are the key lessons? There are kind of 10 or so ingredients in baking a successful integrated care cake, if you will. A person-centered focus on frail, elderly, or other kinds of complex populations with relatively high care needs, including careful targeting. In real estate, it's location, location, location. In integrated care, it's targeting, targeting, targeting. If you're not carefully targeted, you're not, no matter how beautiful your integrated care design is, it's not going to work. Responsibility for identified population and a geographic area, including single point of entry, one place to get into the system when you have these complex needs, and people know it in the community. Case-managed interprofessional evidence-based healthcare, GP on primary care or family physician involvement, preferably an active role. In models where primary care doctors were not engaged actively, successfully, models don't work. So you can design the most beautiful, well-targeted intervention in integrated care. If you don't get primary care doctors to be engaged and to be actively involved, the model is not going to produce the kind of results we know it can. Direct control over a broad package of services, not just medical care, but other health and social and mental health services are required. A heavy emphasis on service and clinical coordination, so care coordination is kind of at the core of everyday work in integrated care. Organized networks of providers. Innovative use of population health management tools and an integrated information system. If you have no integrated information, it's very, very difficult to provide integrated care. Common organizational umbrella or home, including centralized or cross-agency governance and accountability, and shared culture. We underestimate the importance of culture, but if there's not a shared culture, you can't create these kind of very, very complex programs and organizations. An alignment of financial and other incentives, including funding flexibilities. Form follows financing. If you can't figure out a way of creating funding which promotes integration, it's going to be very hard to achieve the kind of opportunities that I'm talking about here today. And it's a bumpy road. Even if you can get the targeting right, even if you can get the design of integrated care programs right, there are still enormous potholes along the way of achieving integrated care. And I'm going to mention some of these potholes and then end up with some observations. Well, first, inertia. There are people who are just only too happy not to do anything. And integrated care scares the bejesus out of them. And I suspect that those who are in positions of power, those who have the most healthcare resources, hospitals maybe, are the ones that are really frightened about integrated care, because integrated care challenges the way the role the hospitals play in communities, the role the physicians play in the medical care and the healthcare system in general. Provider-centeredness. Every organization wants to preserve its role in the system. Inadequate resources, whether it's funding, services, human resources. Supply-driven mentality. During the first American Depression, we had Italian organ grinders that used to have monkeys, and you would give them a nickel, and coming by a nickel in the Depression was a very difficult thing in the 30s, and you gave them a nickel, and then the organ grinder would give a piece of a banana to the monkey, and feeding the monkey, and the monkey would dance. And feeding the monkey is the supply-driven mentality is a very important obstacle to creating an integrated system. It shouldn't be supply-driven. It should be patient-driven, client-driven, patient or client-centered. An overpowering medical and acute care orientation. We have these problems because of that that approach. Turf issues are clearly major problems. Poorly meshed cultures, organizationally and professionally. Misaligned incentives, particularly financial incentives. If we don't have those financial incentives aligned, it's difficult to achieve the full promise of integration. Top-down solutions. You can't build integrated solutions from top-down. So in England, everybody in England is waiting for the government to wave the magic wand or to rub snake oil across the system, or the Dutch would say Harlem oil, so that they can be told what to do. And you can't create systems from the top down, it's from the bottom up. It's from the client and patient and community up, and nobody can tell you how to do this from the top down. If they do, then you know it's definitely not going to work. A lack of stakeholder trust, weak commitment to leadership, inability to manage change, big problem managing change. This is enormous change, and change is better than no change, and those who've been in longest fear change the most. And so integration is a major change, a challenge to change and to change management. Failure to incorporate evidence and learn from experience. People seem to continue to develop programs that are not based on evidence, based on a hope, a prayer, a wish, but no evidence. And unreasonable expectations. And last but not least, some final thoughts. Forget one-size-fits-all integrated care models. I don't think there's one model for Alberta. There's not one model for Ontario. There's not one model for British Columbia or any other provinces. Every community, every population, there may be different ways of achieving the same kinds of outcomes. You need to think carefully about this. Start from where you are. So in the US, we tend to think about fully integrated models. In Canada, you need to think about coordinated models, but you may get slowly but surely, sooner or later, to more fully integrated models when you have the experience. You need to crawl and walk and then run. Success demands social entrepreneurship, innovation, and risk-taking, also time and resource to achieve. There was the Cowardly Lion in, what do you call it? What was the movie? Wizard of Oz. Courage, and you need courage to do good integrated care. And there's a deficit of courage. There's a courage deficit in health and social services around the world. And maybe it's because of the culture of healthcare. And certainly in the UK and England in particular, it's a system where, well, the Dutch have the best way of saying it, never put your head above the grass. So never do anything that people can find out about, and particularly if it could be wrong and go bad. So this is a major problem. Having courage and being an innovator and an entrepreneur is an extraordinarily important part of being successful in integrated care, even if it's a public system like in Canada. Scale matters, and so seriously weigh the benefits of smaller scale community or primary care based models versus large scale regionalized systems. So in the UK they think about large scale systems, but I like PACE, kind of more small scale neighborhood based or primary care based models. I think so for example, building integrated care solutions around primary care or family medicine networks could be an interesting solution in certain parts of Canada. Start from the bottom up and never from the top down. Focus first on outcomes, not cost. In the US, we made the mistake, focused on saving money. That's the American way. And we discovered that we didn't save the money and we didn't solve any of the problems. And in fact, a lot of the early work in integrated care, Stephen Shortell and integrated delivery systems, was like rearranging the chairs on the deck of the Titanic. It didn't create anything but rearranging the table of organization. So you need to really focus on improving outcomes, and therefore, and you can save money sooner or later. Support the development of integrated health information systems as early as possible in the process. It's a fundamentally important to do. Step up education and training in integrated care at all levels. I think it's important that we don't teach people about integration and integrated care, whether they're nurses or social workers or physicians, and I think we need to do that. We need to make it part of healthcare management training, maybe even think about developing masters in healthcare integrated care management or strategy. We need people that understand what integration is and what integration is from the clinical point of view, the service delivery point of view, the financing point of view, the policy point of view, the macro, the meso, and the micro. Make sure programs are evaluated and fine-tuned. We're only now having evidence. It's becoming an evidence-based, empirically driven kind of field. It used to be more art than science, but we don't do a very good job of evaluation. In the US, we have a lot of evaluation lousy system. In England, there's hardly any evaluation. Nobody evaluates anything. And we have to take people's word for it that the programs work. So you need to build evaluation to what you do, and you need to build evaluators, bring evaluators around the table when interventions, programs are being designed. And finally, integrated care is difficult and sometimes frustrating work. Give providers in the trenches as much support as possible. So this is God's work. It is very, very difficult, and you need to think about the people on a day-to-day basis to provide care. And ultimately, if the test of integrated care is it improves outcomes for people that we serve, it also is going to make life better and easier for the professionals that work for them. So thank you very much. Appreciate it.
Thank you so much. No, thank you so much for your stimulating comments, and you've given us information about the evidence and about the concepts and about your observations from around the world. So I know there might be some questions. We've got 3 mics. If people want to ask some questions, you can go to the mics and give us your name and organization.
Hi, my name is Farah Shroff. I teach at UBC, the University of British Columbia, in the medical school, and I'm also doing some work for the Institute for Health System Sustainability and Transformation. And I want to reflect on the comment that you just made about how one of the barriers to change is the top-down nature of our institutions. And I just wrote a paper on innovations and transformations in the Canadian healthcare system, or systems, and found that there was very little in the literature. It was actually really hard to find Canadians boasting about what we're doing, and that's quite a typical Canadian trait. We're really modest. So I had to write to a bunch of my colleagues and say, hey, what are you doing? And I found lots and lots of things. Lots of really innovative things are happening all over Canada in the healthcare system, and people really aren't talking about it. But that comes back to the point that you made about the top-down nature of our system. The change isn't coming from the top. It isn't being written about in government documents, and it isn't really being written about very much elsewhere either. So there seems to be a tension here between the fact that some innovations are occurring on the ground at a small, maybe provider level basis, but it's not integrated, and it's not happening in a large-scale way. There isn't a sort of large-scale policy initiative, despite the fact that something like 300 policy documents all throughout federal, provincial, and municipal governments in our country talk about innovation. Innovation is a buzzword in our country, but there just doesn't seem to be a really good kind of initiative that is integrating all of these integration initiatives.
Any comments?
I think that, well, it's not unusual, I think, even though it may in part be explained by who Canadians are. But I think that you find this in most other countries. In fact, what we do lack is, I've been trying to sell this for years, and that's this idea of having either an international clearinghouse, integrated care, for example. So to know what's going on, there are all kinds of things going on in England and the rest of the UK, and nobody knows about. Strangely enough, in a marketized system like the US, we pretty much know what's going on, and I don't know why that's so. Maybe because in a market system, it's about having advantages and using what you learn and learning about it quickly and mobilizing it in the marketplace. But I think this is an important deficiency in building not only the case but the success in integrated care is having a place, a clearinghouse, that could collect what's going on in a particular country or around the world for different populations, different kinds of settings, what the evidence is, can bring people together to talk about them. It could be information useful for policymakers, or for planners, for clinicians, for managers. Yeah, I think it's important.
Microphone number 2.
Yes, my name is Sharon Noseworthy, and I am a consumer, a patient, and I'm here to talk about the segment of the population that is grossly underserviced. Dalhousie University will tell you that the cost to the Canadian public, to the healthcare system, and to the individual is $15.8 billion per annum and rising. We can turn this around. By targeting this population, we can help them be independent, improve their quality of life, and for the motivated population, we can return them to the workforce and make them productive. However, Quebec is the only province in Canada with a model of integrated care that includes rehabilitation. Without comprehensive rehabilitation, the blind and severely visually impaired are dependent, and yet they do not qualify for home care. In my region, they do not qualify for community care access transportation. So who transports them safely? Who purchases their groceries, organizes their kitchen, checks their refrigerator so they don't contract food poisoning? Other than family, they have to rely on the benevolence of Good Samaritans. Being on low income, most are, they can't afford personal care workers. They don't even know what programs and services could be available to them because they're poorly informed in general. When I speak to the hospital about putting in a first stop post-diagnosis, a psychosocial intervention, I'm told, oh, we recognize there's a need, but we don't have the resources. I hear we don't choose to allocate resources to this segment of the population. We can do better than this. We have to do better than this. Thank you.
Any comments?
No.
Okay, thanks for your comments. And the last 2 questions on mic 1.
Thank you very much. Doris Greenspoon, CEO of the Registered Nurses Association of Ontario. 2 questions. One is in relationship to who should be at the center of the hub of integration, meaning primary care, public health, hospitals, etc. Like when you create the local hubs, even if you create clusters of primary care and you create around home care, hospital, public health, social services, where do you anchor it? That's one question. Based on the evidence. And second, the issue of overlying structures. So in addition to the bottom-up integration at the service level between hospitals, home care, primary care, public health, social services, do you need overlaying structures? Example, in Ontario, we now have 2 structures, right? The local health integrative that actually deals with one part of the system, community care access centers, which deals with the other part of the system. Your comments on that, please.
Well, I mean, I don't know if the literature tells us where the best place is to start. You start from where you are, I suspect. That doesn't really, it's not a very satisfying answer. For example, in Singapore, where they start is the worst, from my point of view, the worst place to start, which is the hospitals, the major academic medical centers. They are the hub of a emerging integrated care system. In some ways, they're responsible for they're responsible, but they are a symptom of what's wrong with the system. It's unable to take care of people with complex and chronic needs. On the other hand, they're the most visible, the most powerful, the most well-funded, the most specialized, most capable part of the health system, particularly a health system where the GPs are very, very far removed from healthcare, don't want any part of any kind of integrated solutions. So these hospitals are creating polyclinics, kind of creating their own primary care capabilities. On the other hand, we know that you can create, as I suggested before, integrated care strategies or solutions or programs or models based upon family physician or family practice or primary care or GP networks. And so I think that's certainly an opportunity, an issue. Or you can build on a community basis. I gave you an example of PACE, the strangest model, I guess, internationally, where a social service agency at the lowest end of the feeding chain wasn't even involved in healthcare at all. It was a recreation and social service center that has become the core of an integrated delivery system where they get payment for all of the medical and long-term care needs of people, and they organize and deliver the services through contract providers, hospitals and physicians, and the rest. So I think there are a lot of different ways of achieving it. What's important is to understand what are the problems in the system, what are the things we need to do to change or to address the problems in that system. How do we build in these 10 or so elements in the system? And I think those are the important questions. How do we target? What's the population we're talking about? And how do we target them well? How do we engage the primary care physician? Extraordinarily important, the family practitioner or the GP or the geriatrician. So that's my first answer. The second question was, well, I want to be politically correct. I don't want to offend anybody because I have some strong feelings about CACCs and LINs. I'm a foreigner here, I'm a visitor, and I would say I wouldn't have done it that way, but then again, that's Ontario. Every province of Canada has figured out a way of approaching integrated care. If you listen carefully and read between the lines of what I said, it's hard to find those things in the system. They exist here and there in Ontario, to be sure, and there are organizations and leaders who understand full well what the challenges of integration are, what needs to be done. But you'd be hard-pressed to really find all of these elements operating on a system-wide basis or provincial-wide basis.
Thank you. So I will add to your comment the word courage.
Maybe it's
no need to be politically correct.
Yeah, courage, or in German it's Mut. Yeah.
I think it's important to challenge all of our models and move to the one that is best. And
based on evidence, yes.
Based on evidence. And in that note, one request in the go forward, yes, it is critical that we engage GPs, absolutely, no doubt they're essential, but I think we need to move to interprofessional discourse and teams.
Sure. So one of the components of a successful model is interprofessional, interdisciplinary care, and indeed, where there are not enough primary care physicians, like we know in the United States, we have a severe deficit. We have advanced nurse practitioners, and they're playing that role. We know that they can do 80 or 90% of what a primary care doctor can do, and in states like New York, they don't require precepting, or in New Jersey, where I live. So I understand. I agree.
And last short question, please.
I don't have a short question. Nobody has a short question. The thing I found interesting is that you keep talking about a bottom-up approach. And once in your talk, you mentioned patients and families as that bottom.
Yes.
Right. And so, but you say nothing about how patients and families might be able to organize themselves in order to have an influence, in order to have an effect on integrating care. I think that the system is so fragmented and there are so many different specialists and so many different fields, and it keeps growing, the fragmentation keeps growing. It's interesting that a lot of the previous attempts at integration introduced new silos. So the idea of having medical ethics, for example, was an idea about integration. And now we have a kind of silo of health ethicists. We had the idea of quality was supposed to be integrative, and it turned out to be its own silo. And now we have integrated care. And integrated professional education is now something you get a master's degree in. Well, it may be that it too will become another silo, just like knowledge transfer and so on. So the question that I ask is, how do you get patients at the bottom, patients and families, to become the basis of integrating care? How do you have that bottom-up happening? Because you said absolutely nothing about how you're
well,
going to
I mean, I could speak for hours and days about integrated care and the minutia of integrated care, but I would say first it depends. So, for example, in the Netherlands, there are platforms. The Dutch government supports patient platforms of various kinds. And these patient platforms have responsibility to inform and advise and to have a stake in how the government and how the non-governmental, the NGO sector addresses challenges of health and social care for complex populations. They definitely have an impact on how things get done and organized in the Netherlands. In the United States, which I'm very familiar with, the most successful models are models which began building their systems, their programs, their models around people, and they began to ask people and their carers, their caregivers, what they believe their needs are, not what the literature tells us. Of course, we know what the literature tells us. We know how screwed up the system is, but we have to ask people, what is it exactly the most important thing to you? It's even the question, for example, of building assessment approaches, and what do we assess? It's not only the typical domains, it's the values, people's values, it's their expectations, you know.
So please join me in giving a thank you to Dr. Kodner.
Visit healthcouncilcanada.ca/symposium to watch more videos from the Health Council's National Symposium on Integrated Care.